So there are 5 abstracts, and apologies, the abstracts of pathology are not there, but I have noted the comments from Dr. Santosh, and I will definitely include that in discussion. We will first start with the adjuvant therapy. There were 2 abstracts of adjuvant, and that makes us about total 4 studies, phase 3 randomized of adjuvant in RCC. Apart from that, there is an evolution now. Just a second, I'll just put this off. There is evolution in the metastatic RCC settings, and there is an escalation from doublet to triplet. And in the last, we have non-clear cell RCC, which was discussed by Ashish. And so to my mind, the ideal adjuvant therapy, and this applies to any oncological setting as well as in RCC, shall eradicate micrometastasis, shall prolong survivals. I have specifically put survival here and not DFS and OS. Along with that, it shall at least maintain or improve the quality of life, and for that it shall have minimal side effects to the whole range of population. And we keep on debating that is DFS a surrogate endpoint for OS and whether that applies to kidney cancer. When we come to the staging of kidney cancer, stage 1 and 2, we all are happy, but the moment we all know the watershed or the plane of Geroda fascia is involved, it is stage 3 or stage 4 without a risk stratification. Of course, a stage 3, stage 4, most of them will land up into a high risk stratification. The risk of relapses are more than 50%. Any comments? Do you agree with this slide that this is an ideal adjuvant therapy in a theoretical world? Okay. So do you risk stratify? And I think it's a small panel. We can have starting from the surgeon. Do you risk stratify your patients, and why do you do it, and how do you do it? Do you risk stratify? Can we have a change of the mic? Can we give another mic,
Hello.
please?
Yeah. So do I risk stratify? Yes, I do. Why I do it? Because every patient is different depending upon the histopathology report. And every patient has a different prognosis and a prediction of recurrences or progression. How do I do it in the OPD? For our clear cell patients and our non-clear cell patients also, we have something called as a Leibovitz score that is available, which has all histopathological features that we enter. And we get a 5-year and 10-year progression-free survival and cancer-specific survival, which I then inform the patients.
Perfect. So Mandeep, you do it for risk stratification.
Yeah.
We ask our medical oncology colleagues, do you do it for a risk stratification, prognostication, or do you do for predictive also?
So currently it's for prognostic stratification, but I think probably now that we will discuss about the adjuvant data, some of these factors will have a role to play in predicting a response to the, or whether aligning the adjuvant treatment.
So Ashish, I was just going through this UISS, and of course these were also there in the inclusion criteria. T2 grade 1, how many of us are comfortable in putting, I mean, of course there are T2 grade 2 grade, but T2 grade 1, how many of us are comfortable in putting it in intermediate and high? Aman, first Ashish and then Amandeep. And then of course.
So I think if you look at the grade 1, that the biology is very, very indolent. So putting such patients into intermediate could be...
Intermediate high.
Intermediate
high. Yes, it's intermediate high. It is not even intermediate. I would have been happy. It's intermediate high, and that goes into the why I'm asking you this particular is because you know that it goes into the trials which we are discussing now.
Correct. So not very comfortable.
Amandeep?
Yeah, not at all comfortable.
Shantanu, if I'm right. Shantanu? No. And okay, fine. And what about these? I will first ask our medical oncologists. Do we risk stratify? Of course, these are the prognostic established risk groups, the Leibovitz as well as the UISS. What about what we have learned from the clinical trials? What about PDL1? What about M1 NED? What about mixed component of sarcomatoid? And what about non-clear cell? First Ashish and then Shantanu. And we can, it's a small panel. I would invite the floor to actively participate wherever possible, please.
So, Randeep, for me, M1 NED is important.
Okay.
Because it's a different disease biology. Though again, the evidence is limited, but M1 NED is somewhere, I will be very, very judicious in making my decision. Sarcomatoid and mixed is very, very important. Partial or complete would not figure into my scheme of things. And PDL1, again, I would not figure into my decision making. So for M1 NED and sarcomatoid mixed.
And
It's
they
very,
will
very
they will
critical.
supersede somewhere over these prognostic classification
Some of
on this
them will
slide.
supersede
Of course,
over these
M1 will go into stage 4, so anyhow that will be a
Correct.
very high risk.
But even sarcomatoid and mixed will supersede, some of these risk factors which have traditionally been given here.
Such as T2 grade 1. No, it will not be ever grade 1 though, but
Correct.
any comments?
No, I agree, sir. PDL1
And
is not a great biomarker.
not a great biomarker, okay. Now we come to the both medical oncologists. In today's era, do we consider adjuvant TKI? See, so before you make the comments, I will make two comments. If we are a hardcore fan of regulatory authorities, then only two things are approved as of 2023 sitting here. One is adjuvant sunitinib, whatever we may debate the data, and one is adjuvant pembrolizumab. These are only two approvals in front of us if you want to play medico-legally safe. So what if the patient is affordable? Will you still consider adjuvant TKI? And if yes, what? Ashish and then Shantanu.
So the length and the breadth of the data with TKI is far more bigger than pembrolizumab. So I would consider adjuvant therapy in M1 NED as we speak.
Okay, interesting.
Definitely I will do it. Now whether I'll use TKI or pembrolizumab, that something is very much debatable. The pembrolizumab data looks impressive. Probably one may shift from TKI to IO.
Okay, and if there is affordability issues or whatever, if there are contraindications for IO, such as patient had some transplant or is having an active SLE, a systemic SLE or an active autoimmune disease going on, then
M1 NED definitely sunitinib.
sunitinib. And among these, there is an Everest trial which is not there on this slide. That was for adjuvant everolimus.
Yes, everolimus. Yes.
That was also there. So Shantanu, your comments, if you have to use adjuvant TKI in one who is financially and medically eligible for IO versus one who is not eligible for IO either financially or medically.
Sir, only for M1 NED, I may consider sunitinib, but otherwise even for sarcomatoid and affording PDL1, that is, checkpoint inhibitor is preferable. At least we have.
Okay. So still in M1 NED we would like to give, and the drug will be sunitinib.
Yes, sir. And for sarcomatoid, definitely.
And in your experience, how is the tolerability? I have not used much. It will be hardly 1 or 2 patients. That has been my practice, and I do submit in front of the house that my actual experience of adjuvant TKIs is very less. I have used in maximum 2 patients in last 3-4 years.
50 mg is difficult to tolerate, sir. For most of the patients, will require some dose reduction to 37.5 at least. So instead of 4:2, many people are using 2:1 schedule also. That is better.
And what is in your practice, if you both can share the experience, any one of you who has used and the tolerability has been fair for adjuvant TKI?
So again, I sort of agree with you that the amount of experience that we have in adjuvant setting for me also is very minuscule. Whatever I have used is this sunitinib in 37.5, 2 weeks on, 1 week off schedule, with which tolerance is fairly manageable and it's a doable regimen. Okay. Adjuvant pembrolizumab, to be very honest, I haven't used in my clinical practice.
Great. Okay, fine. That is the next question.
Do all M1 NED have to go on adjuvant therapy?
Okay. Would anyone in the panel would like to take that, or all NED would like to go for that, and I will come to that comment. Yes, we can have the anyone. Okay, Chirag sir. Would all M1 NED would like to go for? Can you be more specific? Would all M1 NED like to go for adjuvant sunitinib or adjuvant pembrolizumab? You, sir, will answer. Very good, sir. Sir, please answer both of them for us.
My strong preference is towards pembrolizumab.
Okay.
Right? Sunitinib, I don't think abstract included the patient with M1 NED.
No, it did not include. And I think what Ashish and they wanted to say, and I did not comment, was an extrapolation because that is the group which gets benefited.
So, till the data of pembrolizumab came in, my answer to M1 NED going for sunitinib was no. I am not using sunitinib for M1 NED.
But now, sir, today.
Today only. Till the data of
No, so M1 NED not eligible for IO, either medically or financially.
I don't give.
No, nothing. Okay, fine. And all M1 NEDs will go for adjuvant pembrolizumab. That is the next question Amandeep is asking.
I will prefer.
But all financially and medically eligible patients.
All, yeah.
Okay, fine. So we will come to that point again. So again, back to both of them. Will you consider adjuvant IO? There are 4 trials now. The Keynote 564 we all know, that is of adjuvant pembrolizumab for a year. IM Motion 010 as well as Checkmate 914 were presented, and one which was not presented is Prosper. Prosper was 1 dose of adjuvant, 1 dose of new adjuvant nivo followed by 9 months of nivolumab post-op. Only one dose was given before. They have different inclusions criteria, but one thing is common among all these. All of them have at least high risk. Intermediate may be a debatable thing, but high risk they all of them have, and 2 of them have M1 NED, keynote 564, as well as IM motion 010, and most of them have a sarcomatoid. Even Prosper had M1 NED, and we will look upon that data. So with this, again, Ashish and then Shantanu, will you consider adjuvant IO? If yes or no? And we have the data, and you know that there is only 1 positive, 3 negative standing against. And before you make a comment, these are the graphs. The first graph on the right hand upper is adjuvant pembrolizumab, and I'm happy that there is some tail happening, and the tail which all oncologists look in IO trials, the tail is getting achieved here, and that tail is maintained, which gives you some confidence at 30 months of follow-up. IM motion 10010, adjuvant atezolizumab, no tails, checkmate 914, absolutely negative till 48 months. And Prosper again till 36 months or even beyond, there is hardly any separation. So with these 3 standing against 1, Ashish, what will you?
So it's 3 versus 1. I'll always
It's
go for
3
the
versus
majority.
1. Now it has become 3 versus 1. First it was 1:1. Huh.
But again, going back to that previous discussion about the prognostication models, correct? And the risk stratification that we've discussed. So have we optimized them adequately? Does it include all the qualitative as well as the quantitative factors which are required for a risk stratification? I think that's something which is very, very important and still debatable. There is still one only trial which is showing DFS benefit, 3 are negative trial. So if you ask me honestly today, I would probably not do adjuvant IO.
Pembrolizumab.
No.
Okay, Shantanu, your comments.
Sir, I would
And I will come to subsets. Let us have a broad, Ashish, what a broad one, then we dissect out the subsets, of course, because the data is the intention to treat DFS.
I would still be tempted to use adjuvant pembrolizumab in at least M1 NED and sarcomatoid histology.
Okay, so now we will focus on these 2 subsets, M1 NED and O. So I will present the data of all the 4 trials. The first one is adjuvant pembrolizumab. Of course, M1 NED, total number of patients are 50 out of a 700 database trial. The total group, which was M1 NED, was only 60. The hazard ratio was 0.3. The intention to treat hazard ratio was somewhere around 0.63. But adjuvant atezolizumab, unfortunately, the M1 NED you can see on the graph, it is absolutely, the hazard ratio is 0.90, and the diamond is absolutely in the middle, and the confidence intervals are crossing unity. More surprising, even sarcomatoid, yes, there is some benefit, but again, the numbers are much better in atezolizumab trial. If you see the M1 NED numbers, it is 108 patients. Of course, combined in atezo and placebo, there is a better number representation. Sarcomatoid, again, 104 patients out of 800. The hazard ratio is 0.77, again a confidence interval crossed, whereas in sarcomatoid, if you see on the pembro, of course, there was a benefit with a hazard ratio of 0.54. The other true, there is the sarcomatoid, again the benefit is in adjuvant nivo EP. The hazard ratio is similar to adjuvant pembrolizumab trial of 0.3. But in perioperative nivo, when 1 dose of nivo is given, only 1 dose nivo, and it is mainly a post-operative nivo only. Again, if you see, sarcomatoid is not there here, but there is a M1 here. But in M1, again, you can see the diamond you can't see because that is on that line of unity. And there is a wide confidence interval, and the most part of the confidence interval is against using the IO. Now you tell me sarcomatoid and M1 NED. This is what has happened in last 6 months or 1 year. And of course, the toxicity will be added to the M1 NED and sarcomatoid.
So again, Randeep, if you could see, it's very heterogeneous across the trials, and the delta again, of course, is there in pembrolizumab, but just on the small delta number on 1 trial, would you make a conclusion that there is improvement in the invasive disease-free survival? Would you add a toxicity of immunotherapy for such a diminished evidence? Is something which the question that I'm trying to answer myself. So that's what sort of doesn't give me a conviction.
And I will tell you why Chirag sir said very vehemently no is that we all know that when our surgeons resect the M1 NED, these are very small disease, there is a concept, and that is an old age concept, that these tumors will regress on their own once that the parent is removed, and that is what was taught from us, not now, from 10 years, that RCC is a tumor when you remove the parent tumor, and then these micrometastases may disappear. And we have seen initially, I have seen in my practice at least 3 patients who had these small lung mets, 1 or 2 or 3, And they were just kept on observation and they remained on observation after their cytoreductive nephrectomy was done. And that is why it always makes me think that whether we are helping them or not. Shantanu, now M1 NAD and sarcomatoid. I don't know. That is why we are discussing. If you know the answer, I would have told you directly that yes, do this. We don't know. That's why we conduct these points in the discussions and discuss here in the meeting.
Sarcomatoid, I would like to discuss it at least with the concerned patient, even for DFS benefit.
And then M1 NAD, your confidence is shaken.
M1 NAD, yes.
Now the confidence is shaken. Chirag sir, can you help us? And anyone else from the floor? Sir, after this data, you can guide us as what to do.
So in the morning, the same discussion happened, and I said that we should treat the patient with adjuvant therapy where it is likely to work the best, not in the very early subset, not in the very advanced stage where it's not going to work. So I think Ganesh had given the example of the thrombus reaching up to the intrahepatic.
Sir is there right behind, yes. Ganesh sir is there, yes. So intrahepatic, same question, intrahepatic IVC involved or nodes positive. But R0 resection done.
And maybe 3-4 lung metastasis excised totally. That is very advanced disease, and that disease is going to come back whether you treat now or not. But if a 6 centimeter tumor and one lung metastasis is totally excised, so these are the patients who are likely to be benefited the most. So this is the patient whom I will treat. The other patient I will not.
So, but M1 NAD by definition is that all the synchronous and metachronous metastases are resected, whether there were 1, 2, 3, 4 lung or it does not, or even a bone, it does not matter. The definition in all these trials have been that there is no evidence of disease and the metastatectomy has been done.
I will use my discretion.
So is there any M1 NED whom you would put on surveillance? Any M1 NED?
I think
So,
same question what Amandeep was asking before now.
Is there any patient that you can say, ye patient ko I will put on surveillance?
For very advanced disease, whom I think that by the time patient will be discharged, patient will come with some.
So, but then there are more so reasons, sir, to start them on a therapy. If you know that they are going to relapse on the first follow-up, then there are more so reasons to start them now.
The point which I want to make drive is that there are some patients who are very advanced, who are going to have the recurrence. In those patients, I will wait till the recurrence occurs. So there are some patients who are going to be cured without any adjuvant therapy. There are some patients who will not be cured in spite of adjuvant therapy. We don't know who are they. We don't know at present who are they. But applying the common sense, applying the logic that we are applying in day-to-day clinic, I will use my discretion.
And then you will have to stop the therapy at 1 year in these patients.
Yeah.
And also, I think, completely agree with Chirag sir there, and hence probably sunitinib is the middle way.
I think sunitinib will be very difficult to justify because, I mean, either if you have to give it, you give it a adjuvant pembro, else you don't give anything. I think that is my take. And toxicity, there is actually, and that was, I think, comment by Amandeep only, that is that this is a slide grade 3-4. I will just concentrate on clinically significant toxicities. Atezo is 27%. The right-hand curve is the Pembro keynote trial. I'm very bad with numbers, but the grade 3, 4, 5 is 32%. Discontinuation, and again, the Nivo EP, it is around, the grade 3, 4 is 38%. Treatment discontinuation in Nivo EP adjuvant is 32%. And in the Pembro is 10%. And in Atezo single agent treatment discontinuation is, last one, 11%. So it's 10 to 30% treatment discontinuation as you intensify. And of course, you are giving toxicity. It is not a easy regimen in the adjuvant setting as well as others, but these are grade 3, 4. I'm not talking about 1, 2 toxicities here. So to summarize, and we can have comment from all three, starting from Shantanu. Are you satisfied with the trial designs? Both the trial designs were placebo-based. All of them are placebo-based. Yes.
Nivo EP looks like over-treatment with given toxicity, shorter treatment duration is also different. I mean, it is intense and shorter duration, which is probably not justified.
But you don't feel that these trials should have been compared with sunitinib when you have only one approval and the trials, the ones they had started, why they were not compared with adjuvant sunitinib? We all discussed that we will give adjuvant sunitinib, and if these data would not have been there, either you observe them or there is an option of sunitinib. So are you satisfied with the trial design? That is the question.
Probably sunitinib also with an adjuvant setting has a lot of weaker data. Randeep, probably that's
trial
the
design
reason.
is satisfactory.
So trial design is okay,
Fine.
but again, 2 drug for an adjuvant setting, I agree with Dr. Shantanu, it's
No.
difficult, certainly no. Toxicity, apart from the financial toxicity, of course, the monotherapy is fairly okay,
Fine.
which is fine. Practice changing, again, I reiterate, probably at this
So the
point of
practice
time.
changing opposite side, I will say now, is it practice changing that we don't give any adjuvant therapy to any RCC? Rather, it is opposite now. Or you don't give adjuvant pembrolizumab, like you said, I will not give.
So again,
It is every time it
maybe
is
we
not to
could,
give.
the HR, the hazard ratio for the sarcomatoid variant is something which probably one may debate about, and the high risk categories we can probably discuss. But again, the delta is not very big, and again, one trial supporting it. So for me, at a helicopter level, not practice changing, but yes, for a certain subgroup of patient, yes, it will be used in clinical practice. Adaptable to our population, probably if financial are met, then for certain subgroups, yes.
Okay. Shantanu,
Practice
trial
change-
design, yes, no, you just tell. He has given the
No,
comment.
no.
Satisfactory trial
No,
design?
no.
No, you're not satisfied. Toxicity?
No, not acceptable.
Not acceptable. And practice changing? To give or not to give, that also you tell. Practice changing to give adjuvant or not to give
To
adjuvant?
give adjuvant after discussion with due discussion
So you will
in
still
selected
consider?
patients, yes.
Okay, and that it can be adapted if finances are met. Amandeep, any separate comment?
That's all.
No. Okay. So we will shift gear to metastatic RCC. No doubt that combination is the flavor, and sunitinib has no place in, sunitinib has some place in today's era. It was a wrong statement to make that sunitinib has no place in today's era. But in the guidelines and in the richer part of the world, they have totally eliminated. And yes, most of us are following that there is a combination in all subgroups, good, intermediate, and poor. There are many more trials. I think the major ones I've mentioned here, except the evolumab axitinib, which has gone out of fashion, the Ipi-Nivo, which is only IO, and there are 3 more trials. The trial, this is just to put the things in perspective, that the hazard ratio in the PFS and OS are almost similar. If you see 0.7 is the hazard ratio. Why the Checkmate 9ER and CLEAR trials are showing a very good hazard ratio? Don't get carried away. Their follow-ups are very less. They're just 23, 24 months. So that is not, but OS, all of them are hovering around 0.66, which is a clinically and a medically significant. There are other differences, of course, that the combinations of Nivo, Cabo, Pembrol, and Nivolumab are more active. And there is a difference of poor risk. The CLEAR trial, which shows you very good results, had only 9% poor risk, which is the least. And to my mind, Nivo, Cabo appears to be best. It has 20% poor risk. And in spite of that, they have done well. And we have a follow-up data, which was presented by the speakers, and they have the PFS is holding to 0.73. Chirag sir, your comment, and then we come.
So my question is to any of the panelists about favorable risk.
Okay.
The recommendation you said that all 3 combos are preferred.
Okay, sir, I will include that. Please give me time. I will include that. So where do you place update Checkmate 9ER, and then there is the Cosmic data. Cosmic data was, so let us start with Checkmate 9ER, and this was the slide, sir, where the hazard ratio for the favorable is also put. So let's talk, where do you place Checkmate 9ER? Follow-up data of 44 months, which is a good enough. And then there is a triplet also here, which is a Cosmic. Before you make comments, I will just summarize this slide. Cosmic, one good thing I liked about Cosmic is a very early separation of curves starting at 3 months. The tail is maintained, but 35% of the patients did not underwent nephrectomy. And when we talk about Ipilimumab, this was not brought up by the previous speakers, percentage of patients who were receiving 4 doses of Ipilimumab is 58%. And yes, there is a hazard ratio of 0.73, which was statistically significant for the intention to treat. So where do you place them with this data set? We can start with Shantanu and then Ashish. And then, of course, the comment was about favorable, that even in the 44 months of follow-up, the Checkmate 9ER hazard ratio for survival is standing absolutely at 1.07. Exact unity with a confidence interval of 1.6 to 1.8.
So before the answer,
Yes, sir.
add that in all 3 trials,
All 3 trials, yes. It is all 3.
the hazard ratio is almost like that.
Yes, yes, sir.
It is preferred.
Agreed, sir. This is all 3 trials that is like that, because I have not included them because my abstracts were 9ER and this. Shantanu.
So triplet to me
So
looks
where do you place 9ER first follow-up? Does it changes or no? You are still happy? I mean, if you are a fan of Nivo Cabo, you are still a fan of Nivo Cabo.
Yes,
This
sir.
data does
Nivo
not
Cabo
dissuade you
looks
to.
feasible.
And do you-
Cosmic looks difficult, sir. Triplet with given toxicity and OS data yet to come looks difficult.
Okay. And for favorable risk, will you do a sunitinib or a cabo-nivo or a cabo-nivo-EP?
Sunitinib alone.
Sunitinib alone yet?
Yes.
Okay. But there is a very positive PFS data. If you see, there is a 12 months difference in PFS even at this follow-up, 22 months versus 13 months. So it's almost doubling of PFS. So you don't want your patients to live longer without the disease because their survival is still limited.
So, Randeep, can I comment?
Yes, your chance.
First one, the triplet is no. Triplet is definitely no.
Okay. No for favorable, na? But no for everyone.
Currently,
Right now.
I believe no for everyone.
Okay, no for everyone. Okay.
For the 9ER, again, I am very comfortable with Nivo-Cabo combination. So, cabozantinib combination, so that is good. And even for low-risk patients, I would tend to use a combination because the PFS benefit is quite conspicuous, unless the patient is financially challenged.
So if there is no financial challenge, then what will be the medical reasons to give sunitinib in a favorable risk? No contraindication medically and financially for immune checkpoint inhibitors, then what will be the medical subset of favorable risk where you would like to give sunitinib? Anyone or zero?
I will use immune checkpoint inhibitors combination.
So there is a zero. If they
Zero
are
for me.
medically and financially eligible, like they are good performance status and they have no finance problem and no contraindication to checkpoint and others, you would like to use sunitinib in anyone. Shantanu, your favorable risk, anyone you would like to use? Someone who has a maybe oligoprogression post, I mean there is just 3-4 mets in the bones, or they have progressed and they have been on observation and
Only
somewhere.
for histology probably.
Histology is clear cell. We are only talking about clear cell.
Sarcomatoid.
No sarcomatoid here. No papillary, no clears. That will come later.
Sarcomatoid is included in clear cell.
So this is clear cell. We are talking about clear cell. As actually 95% inclusion criteria here was clear cell in all these trials. 90 to 95% the patients have been clear cell in all these trials. So anyone eligible, anyone you will put on single agent sunitinib Monday morning? Okay, Chirag sir, you got your answer.
I will give sunitinib only. And whole world, nivolumab and axitinib and cabozantinib and everolimus with lenvatinib and subsequent line of therapy. And that gives me equivalent survival. So why do we give the combo in the first place?
So both of them can answer. Why would you like to give the combo when the patients are surviving same? I gave my reasons that the PFS is doubling, so I gave my reason that it is 13 to 24 months. I am happy with the patient living for 12 months without disease free, although they are living same. Or they are living, I mean, they're starting at one point and they're dying at one point in a similar way. But I am happy if 12 months they are happily living and they are tolerating the regimen, of course.
Yeah, I think the tolerance is very important for a low-risk patient. If suppose we have a combination regimen which we are comfortable in doing it, then this almost doubling of progression-free survival will be conspicuous for me, and that's probably the reason that I would probably consider using a doublet even in a low-risk patient.
Okay. And now what about triplet? Chirag sir is not happy with the answer, but fine. I stand with Dr. Ashish. This is our take on the data. So what about triplet? And this was the stratification, and what was sir talking about is in the all, this was the slide of pembro axitinib again. I mean, these are the, if you concentrate on favorable risk, actually what Dr. Chirag sir was suggesting is that wherever we are concentrating on favorable risk, the confidence intervals are wide, and somewhere like in Nivo Cabo data, the hazard ratio is 0.8, and even in the Checkmate 214 and Cosmic don't have the good risk, so they were not included. Now what has been surprising is this thing. If you can help me to, both of you can help me, or anyone from the house can help me to explain why this happened when we are using triplet. In the intermediate risk, there is an early separation, and the response rate is 10% better. And if you can see, hazard ratio is 0.63, which is clinically as well as statistically meaningful. But in poor, not early, not late, at 9 months, the curve has actually crossed, and the orange bar, which is a triplet bar, has started doing worse, thus making your confidence interval wide, hazard ratio at 1.04, and thinking that when you are escalating the therapy, are you harming subset of patients, and why has this happened?
So honestly speaking, we don't know why did it happen.
Okay.
Correct. Because the
Shantanu,
trial.
you can help me. Why did this happen?
No, sir.
Okay. Anyone, I mean, this is, it is of course an hypothesis. Once a thing happens in clinical trial, it is difficult for us to explain. So I will take this question. What I feel is this slide. If you see the toxicity and the usage of steroids, I mean the toxicity of the combination, which is the maroon bar, is standing at 75 to 80%. These are again clinically significant toxicity. And you see there is a significant discontinuation as compared to others. I mean, if Nivo-Cabo is the orange bar and those are the same colors on the projector, if the Nivo-Cabo is the orange bar, you can see that at least discontinuation is less than 20%, usage of steroid is less than 20%. But the moment we escalate to triplet therapy, the discontinuation is going beyond 40% and the usage of steroids is touching 50%. So what I feel is that when we escalate the therapy, if we are using steroids, we are even compromising on the efficacy of Nivo-EP. And if we are discontinuing, I think most of us will agree that as a clinical investigator, though we may say in clinical practice that when toxicity will happen, तो हम एक बंद कर देंगे, दो चलेंगे. It is in clinical trials mostly there are stringent criteria, and if the Nivo-Cabo EP is causing toxicity, it will definitely hamper the dose intensity of Nivo-EP also. And that is the reason that the patients who are poor risk are already compromised. And because of their clinical compromise and poor performance status, they would have landed up in not even receiving one of the regimen or a dual regimen properly and this is in a clinical trial setting. Imagine what will happen when we use it in a practice.
So I think the reason I did not mention about toxicity is because of the fact that then if you have an analogy to that, then probably the intermediate risk also should not have seen so much of conspicuous improvement in the hazard ratio.
But the chances, I don't have that data that how much discontinuation steroid was used, that will not be there till the full text.
So that's exactly the reason I mentioned that I don't know, because if you just look at toxicity alone, then probably it has to be present across the subgroups, correct? But it is conspicuously very, very staggered towards poor risk group. Then why? So that's the question. Probably more detailed literature would probably give us the answer.
Full text when you have.
Full text.
Shantanu, any comments?
IMDC, that classification is not validated for these immune checkpoint inhibitors, particularly with addition.
To some extent, yes, we can say, but then that should have been seen in all the other 5 randomized trials that the poor risk is not doing well. Only it has happened in this triplet that poor are doing worse. And it is absolutely a big difference of 0.63 versus 1 in the hazard ratio. It's not a 0.6, 0.7 and 0.8. So coming to let us talk about Cosmic and have the comments from both of you. First, Shantanu, trial design is satisfactory?
No, sir.
But why? I will say this is the best trial design. If you can compare a Nivo-Cabo with Nivo-EP, what else you want? You are comparing it with sunitinib. When we were comparing with sunitinib, we said that pembroaxitinib should have been compared to axitinib, or Nivo-Cabo should have been compared to cabozantinib. But here you are having it's a better comparator arm. I don't think so we can have. It is a challenge on the investigators.
So trial design is good. It's like you are having daratumumab to BLD. Try to make poor risk better. So the trial design is perfect. The concept is good.
What they have achieved another 10% improvement in PFS. Forget about the toxicity has been over Nivo-EP, which is your best arm as of today still.
Correct. So the trial design is fine, that you want to improve outcomes in a poorer biology patient. So which is fine. Toxicity is not acceptable. It is definitely not practice changing. Adaptable to our population is probably no.
Okay, fine. Any comments from the house? We go to the next abstract. Yes, Shantanu, please.
Sir, how about the trial design containing Cabo, Nivolumab plus minus Ipilimumab? That would be a better comparison probably. So that continuation rate might be better without Ipilimumab.
Ajay, you want to say the comparator should have been Nivo-Cabo?
Nivo-Cabo.
We don't have the trial. That was in your mind when you said that. Why Nivo-EP was chosen. Okay, fine. Coming to the last part of the trial, and this we can cover up fast. This was about non-clear cell RCC. Ashish has actually summarized it well. I will just concentrate on papillary RCC here because and he did mention that when you talk about non-clear cell RCC, 80-85% of the patients are actually papillary, or 75% are papillary in this subset. And papillary RCC is very different from conventional clear cell RCC. So Ashish, you have already given your comment whether you would, so here you would like to give a single agent versus combo. Here is a space where you like to give single agent or a combo, and which is the single agent here? Shantanu, you first, and then Ashish has, I think, already said yes.
Sir, combo, sir, because we are unlikely to get much of the data, much phase 3 data anyways for these kind
But
of
then why
patients. So
will,
whatever
if you don't have a phase 3 data, then how will we give a combo here?
PFS benefit, whatever we have with combination, I would be happy with it.
Okay. Ashish, which combo?
Pembro actually.
Pembro which was presented. Okay. Ashish.
Pembro is what I've presented, but the data is predominantly for nivo cabozantinib. You have a very good data for lenvatinib plus everolimus. That is also a data which is there, and a axitinib monotherapy. In fact, lenvatinib plus everolimus is something which was across non-clear cell histologies.
That is there here. Yes, actually.
Yeah. So I'm actually been using lenvatinib plus everolimus in many of my non-clear cell histology patients. I haven't used IO plus TKI combination in this group of patients.
Perfectly. But what will be your first choice of Monday morning?
So
Let
Monday
us say it is type 1 RCC and type 2. There are two papillary RCCs patients. One is type 1 and one is the hereditary fumarate hydrate deficient proven or no NGS done.
So no NGS done, but the hereditary papillary renal cell carcinoma, I would still have used bevacizumab plus erlotinib.
Okay. There is a data of bev-erlotinib as well as the tizo-erlotinib, and for the type 1 RCC non-hereditary, you would use a combo or a single agent?
I will still use a combo of lenvatinib plus everolimus.
Lenvatinib plus everolimus.
Because that has got one of the best data.
Sir, yes, I will come to this is the data which is one of the largest database. Unfortunately, this is also, I think, only of 100 patients. And this is a SWOG 1500 subset, a phase 2 trial. If you are using a single agent, it has shown that cabozantinib is best because cabozantinib acts on many targets, and MET is one of the target which is very popularly exploited in papillary RCCs type 1. And that is why if you have to use a single agent, it shall be always cabozantinib. And then you can use a combination of nivo-cabo also if you wish to. And then type 2 RCCs are treated separately. Yes, sir.
So that was the comment which I wanted to make. And for chromophobe, there is evidence of pit and loss. And for pit and loss, everolimus is a better drug.
Yes.
So I will want to use everolimus with lenvatinib.
I think that is one of the best combinations as of today. And then there, even in the guidelines, why cabozantinib is recommended is because of the strength of data. Otherwise, we all have phase 2 data only. I think in the last, I will take 2 comments from the panel. This was regarding Dr. Santosh Menon's inclusions. First was very interesting that I will start with Amandeep. Amandeep, how many patients you are working at a high volume center? And others, if there is any other surgical oncologist who can cover up and help us with this question after you first. Post ICI, do you do nephrectomies, and how is your experience?
Yeah, so our intermediate risk patients who've had a year of
No, neoadjuvant ICI. They have received some sort of neoadjuvant therapies, neoadjuvant ICI, anything. I mean, not talking
so
about.
our intermediate risk patients with 2 or more factors who were planned for systemic therapy first and then possibly a interval nephrectomy. So if they've had their 1 year of therapy and they've shown a good response. We've had few, not many, I can probably count on my fingers. We've done them. The nephrectomy is not more difficult or easier than any other nephrectomy. It's definitely not more difficult.
And what are your, and how do you response assess? Do you do an, I mean, a PET scan is fine, or a MRI or whatever, do you assess them in the same way as you would do for anything else?
Yes, there's nothing different than assessing.
And what will be that? Suppose on a baseline to do for an RCC, you will do a CT-KUB basically.
Yeah, but I think here we do a PET and then decide.
And then you follow up with the PET scan.
The follow-up is done with the medical oncologist again.
But you have to operate, na?
Yes. So the medical oncologist has assessed that the response has been good. Then we discuss in an MDT whether adding surgery to this patient would be beneficial. That PET scan is enough for me to assess effectability.
So we will be also, if someone has done a PET scan and there have been a 1 or 2 oligo or other, we will be also doing the same scan only. And anything else, Ashish or Shantanu, you would like to add and Dr. Santosh did mention that the pathology is also challenging. It is not only the clinician's problem when you give neoadjuvant ICI in a new disease, and giving neoadjuvant new immunotherapy in RCC is definitely something new for all of us. Shantanu, any comments? I don't have experience of giving neoadjuvant ICI yet in my patient. No experience. Okay. And the next comment, I think that is simpler. We can have comments from all 3 of the panelists. We all face this, and this was very interesting that we all know the guidelines of doing BRCA testing in breast, as well as we know for colon, doing Lynch and prostate. But as a medical oncologist, we have been more comfortable, and we have been taught, and by heart we remember the breast guidelines like 1 relative, 2 relatives and all that. But Dr. Santosh made a very good comment that how much we are pepped up as a medical oncologist to do that, follow the guidelines for prostate. And here we are talking about prognostication and family history. We are not talking about using our PARP inhibitors in the future. Shantanu, and other histologies, especially cribriform and intraductal, do they make a difference, or you would like any young patient who is fitting the criteria, irrespective of histopathology, to undergo pre-genetic counseling followed by BRCA1-2 testing?
Yes, sir. All young patients with low PSA, particularly low PSA, high Gleason.
Low PSA, high Gleason. Okay.
It's not typical.
Maybe these.
So in fact, that paper also it said that the BRCA is histopathology agnostic. So
yes, he meant that.
That is what was mentioned, I think, Doctor. And so for all young patients, yes, BRCA, yes, but coupled with the genetic counseling, just not writing a BRCA prescription. That's very important.
Amandeep, your comments?
Yeah, so honestly, we don't do it, although it is there in guidelines.
Look, because breast unit, they are all do it. And even now we have also...
So the guidelines say for all high risk and for all metastatic, honestly, we don't do it. But if we have to do it, then yes, definitely genetic counseling along with the testing.
But for everyone who fills the criteria of the guidelines, and these guidelines have been issued
Ideally,
not
yes,
by
so I think it is
the
at least
South Asian, these are all guidelines from the Western world.
Yes,
How
I
much
think
will
it is
they
at least
adapt
our
to
job to inform the patient that you are not the routine prostate cancer patient, and we have evidence that we should be doing genetic testing in you, and then I think it's up to the patient also to decide.
Okay, fine. I think we are come to the end. I will just summarize. These were the points which were discussed, and I will just put my comments to it. High risk RCC, I would like to keep them on surveillance, but for sarcomatoid and M1 NED, I would definitely like to discuss about adjuvant therapy. My choice for adjuvant therapy will be pembrolizumab if me and the patient and the tumor board agrees that they shall be treated with some sort of adjuvant RCC. For good risk, definitely single agent sunitinib will always be there on the card, but my preferred combination will be, this is my personal choice and my experience. It is not that one is better over the other. I have been using Nivo Cabo, and it is just about your comfort level. It is not that Nivo Cabo or Nivo EP or Pembro axitinib as well as pembrolizumab. There is definitely toxicity, but it is about your experience, how you learn that how much cabozantinib you want to give. That is also very important. And my preferred combination remains Nivo Cabo. For poor risk, I may still like to give a Nivo EP. But while choosing these combinations, I do keep in mind that my patient, the moment I use a IO-IO combination, I have to give the time for the patient to respond, because the rapidity of response reduces. So always use the combinations with which you are comfortable and you know you can manage the toxicities and make your patient's quality of life better. For non-clear cell RCC papillary, my first line choice will be cabozantinib, and after that, if it is type 1 RCC, I would like to use a combination such as pembroaxitinib or even lenvatinib everolimus. And for hereditary RCC, I would like to use erlotinib with BEV or atezo with erlotinib. And this is my take on the data, and of course there will be some ifs, buts and wrongs to this statement. Thank you.